Alrighty, so the final talk before crawfish and cocktails is an overview of palliative care. Long before we had evolved the ability to develop treatment-specific care, we were able to provide comfort and support to our fellow men when they were injured or ill. And that's basically the foundation of healthcare, and that's what palliative care is all about. So it was possibly our first medical specialty. So my disclosures: I'm in the Speakers Bureau for AstraZeneca. I'm the Medical Director of Concerned Care, Home Health, Palliative Care, and Hospice. My other disclosure is Troy Bourgeois is my physical therapist, and he and his team have just helped me through a rotator cuff injury, and I'm probably going to start for the Cubs this season. So I want to do some definitions. The reason being there's been some evolution in the nomenclature of palliative care, and sometimes it can be confusing what we're actually talking about. So we're going to go through some definitions. So palliative care is an interdisciplinary medical caregiving approach aimed at optimizing quality of life and mitigating suffering among patients with serious complex illnesses. It's a very broad form of care, and pretty much everybody in adult medicine and a lot of people in adolescent and child medicine provide some level of care. It became a distinct medical specialty in 1990 because as disease-specific therapies evolved, so too did palliative care. And it's provided in a variety of contexts based upon needs. It's the precision medicine of comfort and support. And by that I mean we need to meet patients where they are. Where do they live? What's their support system like? What are their specific diseases and needs? And then it can be the primary goal of care or given in tandem with disease-specific and potentially curative treatments. So it's very applicable to what we do in a lot of oncology. Hospice is a very specific form of palliative care. It's the type of care focused upon the palliation of a terminally ill patient's pain and symptoms and attending to their emotional and spiritual needs towards the end of life. Generally limited to patients with a life expectancy of 6 months or less, but we rarely are able to pinpoint how long someone's going to live, so sometimes patients do stay longer in hospice than 6 months. And family support is emphasized during the care of the patient and afterwards. So even after a patient has passed away, we perform bereavement services for the families. We keep them involved in our care for a long time. It becomes sort of a supportive family for folks who have lost a loved one. But let's talk a little about what hospice is not. Hospice in some circles is kind of a dirty word. People think, oh, that's where you go for your last 2 days of life, or all they do is put a morphine drip on you, or it's never ever the cause of death. So when we bring up hospice sometimes, people are like, no way. My brother-in-law went into hospice, he was dead in 2 days. It's because he had a disease for which there was no cure, and hospice was his final level of care. So it becomes important for us to try to educate folks on what we can do with hospice and that it really is a very important component of care. So treatment with palliative intent, and I'm going to spend a minute on this because a great deal of what we do in medical oncology is treatment with palliative intent. A patient has a disease for which there is no cure, but we are going to be able to help them live longer and live with greater quality of life by virtue of what we can do in medical oncology. So this involves things like surgery, radiation, chemotherapy, and now an arsenal of new pharmacologic therapies for cancer. But for us to be able to help patients live longer and better and to administer this safely, I need help from Troy, I need help from Erica, because they enable us to do these dangerous things in a way that's safe and effective. It turns out we need an army of supportive care personnel to deliver effective cancer therapies in 2024. It's definitely a multidisciplinary specialty. So I had to throw in a show tune lyric here. So who can get this? To people living with, not dying from disease. Song and show. Don't make me sing. Okay, it's La Vie Boheme from Rent. So if you don't know what Rent is, it's young people living in the East Village during the AIDS epidemic of the mid-'80s. And most of these people have AIDS, and at that time, it was considered uniformly fatal, and your life expectancy was maybe 18 months. And they were saying, you know what, we're not going to die from this disease, we're going to live with it as long as we can. Well, flash forward to today, a person diagnosed with AIDS right now could live a normal life. Their life expectancy is well beyond 10 years, and it depends upon if they get good care or not, or have access to care. So let's go back to the 80s. The median survival of multiple myeloma, 2 years, maybe 3 years. Now it's 8, 10, 12 years. So people are living 8 to 10 years longer with this disease. The care we're giving them during those 8 to 10 years is palliative care. And so there's been a paradigm shift with many cancers. A lot of us will have breast cancer patients living with low volume metastatic disease on a treatment that's well tolerated and having a fairly normal life. The shift is cancer is being transitioned slowly from a disease you die from to one you die with. And that's a victory. If you can live with that cancer and have a normal life, then that's almost as good as a cure. So just looking at adult medicine, though, a tremendous amount of adult medicine is, in fact, palliative when you think about neurologic diseases, CHF, Parkinson's, things like that. So it's part of everything we do now in medicine. So palliative care is holistic, and cancer care, to be effective, is going to take into consideration the whole person. And these are 8 points of things that we deal with our patients. The top 2, the physical manifestations of disease and adverse effects of therapy, that's probably 80% of my personal patient encounters. The more sick someone is, the more complicated things are, the more time that gets shifted there. And unfortunately, that means some of these other things don't get enough attention. That's where I have to engage other providers in care. So psychological, social, spiritual, existential distress, these are very difficult things, and they adversely affect our patients' quality of lives. There's no pharmacologic remedy for this. This involves time, conversations, teaching them methods of dealing with it. And it takes more time than our clinic visits often allow. So it's another circumstance where we have to get help from other people. Financial distress is something that I find particularly troubling because there's oftentimes nothing we can do about it. We live in the richest country in the world, and we're the only country in the world that has something called medical bankruptcy. You can work your whole life, have health insurance, and go broke because you got cancer. And I find it personally unconscionable that we do this, and that's one of the things I think that's driven me to be part of CAGLA, is we're trying to find ways to help people manage that part of their sickness. Cultural concerns are very important. What people need at times of illness is very dependent upon who they are, their culture, their faith, things like that. As providers, we have to be very sensitive to that, understand where they're coming from, and again, meet them where they are. And then caring for loved ones and caregivers. I always say that when a patient gets cancer, a whole family gets cancer, their tribe gets cancer. It's not simply a broken ankle, you go to the doctor, you get an ORIF, and everybody's fine. This is something you may have to live with a long time or may not survive. So we want to take care of whole families. So the major clinical areas, the interdisciplinary team, physicians, nurses, administrators, again, it's a very big team, and there's a little bit of a difference in palliative care. In the operating room, the surgeon and the anesthesiologist deliver the vast majority of the care. The other folks in the OR are providing support. In the palliative care IDT, the physician is less of a leader and more of just one person on the team. The reason for it is most of this care gets administered away from the clinic. I sometimes won't see patients very much, particularly if it's home care, and so I depend a whole lot upon this team. Nurses do the majority of the work. Our administrators allow us to get care delivered in a way that can be managed financially. That's always a headache for us. Dietitians are so important because nutrition and hydration is very, very important at folks, particularly in the hospice setting where they're having end-of-life care. Weight loss, things like that, pressure sores, all of this requires a lot of attention. Chaplains are very important to people of faith. To some people, maybe not. We have to be sensitive to what their wishes are and make sure we get them what they need. And then family and friends and network. One thing we know is the better support you have from your family and friends, the better your outcome's going to be. Everybody plays a role in helping people in this difficult time. And then the flip side of that is we need to help them as well. So the major clinical areas, all of these could be a lecture all by itself, so I'm not going to spend much time on it, but I want to say a few words about pain management in the hospice setting. When someone comes to clinic and I'm addressing their pain, we're face to face. I can do a detailed history I can use a visual analog scale. When someone has pain at home, it's a little harder to get an accurate measurement. And it also involves people taking narcotics at home, people who are getting assistance from family members who may not be health professionals. So there are some challenges there, and we have to really stay on top of drug use, pain scores, and making adjustments. So what are the financial considerations? The primary financing mechanism of palliative care are specific benefits within Medicare, Medicaid, and commercial health plans. And that gets 3 asterisks because coverage is highly variable between plans and they're typically underfunded. Though palliative care is highly cost effective, very, very efficient, it's typically underfunded because people are not that familiar with it. It's a little bit like mental health care. Extremely vital, doesn't get much funding. That's something that on the CAGLA side of things we can work on, and we're going to talk a little more about that. So about 10% of all health care spending in the United States goes towards end-of-life care. In 2018, that was $365 billion. Now, here's the problem. That end-of-life care often did not provide the comfort and support patients needed. That person with pancreatic cancer who has just a couple of weeks to live is better cared for in home than in an emergency room where they're obliged to do aggressive things. Because you came to the ED, I'm giving you a CAT scan, I'm drawing blood, I'm going to do a whole lot of extra things that may not really benefit you. It's not the ED doctor's fault. He's faced with a clinical problem. He's going to use their protocols. Our job is to help these people stay home and get the care they need in the right setting. Palliative care, again, less expensive and more cost-effective than disease-specific chemotherapy. We've been able to show this in clinical trials in lung cancer where in patients with a poor performance status who have already been through 2 lines of therapy, they lived longer and had less expense if they went into hospice than if they tried some 3rd-line chemotherapy. That's always evolving because we now have some better drugs. So it gets back to what is the patient's performance status, what's their probability of success with the treatment, what's the toxicity profile. ChatGPT ain't going to be able to do this, y'all. This is about people who really are in the room with the patient, listening, and making complicated decisions. So what are the barriers to ideal care? Misconceptions. Hospice is not well understood. How do we defeat that barrier? We do things like this. We talk to folks. We try to explain what hospice care is and what palliative care outside of the hospice setting is so that they don't immediately have a barrier and refuse to take it. I would say hospice is an area where there are more people who don't get what they need because they just don't want it. Nobody ever tells their primary care physician, no, I'm not going to the cardiologist for this MI. Not going to do it. Of course not. Cardiology is cardiology, hospice is hospice. So lack of candid communication. It is probably one of the biggest problems in talking to people about the end of their life, that we cannot always be as honest as we need to be. Oncologists, we do it all the time, so we're probably a little better at it. Primary care doctors who take care of older folks, a little more experienced, but a lot of docs are very uncomfortable talking about dying. I'm a medical oncologist, it still weighs heavily on me. I don't feel good about myself when it's over, but I know I have to be honest and I have to give them the opportunity to make good decisions. I've had to do this with family members. It's heartbreaking, but it's just part of the job. So the last 2 things, time and human resources, access and availability. I'm going to use this to talk a little bit about the CAGLA process. So recently, I guess 4 or 5 months ago, one of our last CAGLA board meetings, we wanted to talk about what legislation we would like to bring to the 2024 session. And one of the things that came up was one of our GYN oncologists said, I can't get my patients home health if they live here or there. I can't get them hospice. They keep getting denied. How do we do this? And so we wanted to look at reasons why people may or may not be able to get access. So it might be that your payer is not one that's going to go to your part of the state or city. The person that covers that is not in your program or not in your plan. And what hospices and palliative care organizations do is they have a 50-mile radius. If outside of the 50-mile radius, you can't do it. So trying to match patients with the proper vendor can be challenging. I'm not sure there's any good ways to solve that problem, so what I did is I contacted 2 hospice owners that I've worked with in the past, one I'm currently working with, and I asked them, what can we do about this? And then I also talked to some directors who ran hospices, and I got a whole lot of feedback, and 2 things came up that they thought would help. One is, if you increase reimbursement for our services, it helps us hire more people and cover a broader area. The second one was, relax some of the guidelines about admission. Don't make us pull somebody out of hospice because they haven't declined a certain amount fast enough. And so those are things that are potentially addressed in a legislative fashion, and that's where we are right now, is trying to figure out how to do that. I got a conversation going between a lot of people in the hospice world and some of the doctors, and so we're going to try to pull together and see if we have a legislative solution. I'm not sure that we're going to have something good this season, this session, but we're working on it. But the good thing that did happen is we got a conversation going, and I had some hospice owners saying, you know, I don't go to that part of the state, but you do. Maybe we can communicate. If I have a patient and they're outside of my 50-mile radius, but in yours, we'll do that. Or they're both, you know, I don't take their insurance, you do. Maybe we can work together. That's easier said than done in a competitive marketplace. But if we get them working together, we may be able to come up with a solution. So, you know, what CAGLA can do here is help enable those conversations and then maybe bring some legislation into play to help us out. So what I want to do before finishing up, are y'all familiar with the TV show St. Elsewhere? Okay, so St. Elsewhere is from the 80s, medical drama. I filled out my application to medical school, sitting on my parents' floor watching it. And it was a show about an urban hospital in a poor part of Boston. Think of big charity in Boston. But instead of the Daughters of Charity, it was run by the Archdiocese of Boston, and it had a priest, a tough old Irish guy named Joseph McCabe, who was their administrator. And they follow him along from his childhood through his early days until he finally is in hospice himself. And what happens is he gets amyotrophic lateral sclerosis, Lou Gehrig's disease. He becomes debilitated. He has respiratory problems. He moves to Arizona and goes into hospice. And then St. Eligius gets this state-of-the-art computer-driven radiology system, and they ask him to come back to do a dedication for it. And he's, you know, very honored. And so he comes back to Boston in a wheelchair. This big strapping guy who just kicked everybody's ass for 30 years is now very fragile and weak. And when he gets there, what he says is, the basis of medicine is not a computer printout, but the mind that created it, the rational mind that knows what to do with the information, the compassionate mind that teaches and counsels and loves. I tell you that because I almost forgot it. So we've gone from, you just attended a conference where you saw cutting-edge, state-of-the-art things that when I was a fellow were unfathomable, that we're doing every day now. But the thing that really matters is the drive, the compassion, the caring, and that's what drives scientists, it drives nurses, and it drives doctors. And I actually have this written down in my desk, so I know it's a little weird, but you got to remember that. And as healthcare moves forward, it's going to be us. And you know, we do this not because it's just the only way we have to make a living, because it's very much in our hearts. So that's everything I have. You can ask questions if you want, or you can dash off to the crawfish boil. So. Thank you. Oh, I do have to show my picture of my kids. That's them. All right, guys, that's everything.